This podcast is not meant to be professional advice of any kind. It is meant to be informative and entertaining. If you make any changes to your life, see the appropriate professional before you do so. What kind of super ager are you? Go to ageist.com/quiz. Take the super ager quiz, and we'll send you directed, personalized information to help you super age the best that you can. Welcome to Super Age. My name's David Stewart. I am the founder of Ageist and your host on the Super Age Show. We talk about how to live healthier, how to live longer, and how to be happier. And who doesn't want that? Today's show is brought to you by Timeline Nutrition with their breakthrough product, MitoPure, the first clinically tested urolithin A supplement, which is showing tremendous results for mitochondrial health. Go to timelinenutrition.com/ageist, use the code ageist at checkout, and save 10% off your first order of MitoPure. Today's show is also brought to you by Ned's Mellow Magnesium, designed to help busy people sleep better. Go to helloned.com/ageist and save 15%. Get yourself some better sleep. Today's show is also brought to you by Divi, hair care products specifically designed for men and women who are concerned with hair loss and scalp health. Go to diviofficial.com/ageist, save 20% off your first order. Welcome to episode 157 of the Super Age Podcast. We'll be dropping this on October the 25th, 2023. This week on the show, we've got Dr. Alan Reznik, and he's an orthopedist, and he has a new book called The Knee and Shoulder Handbook, The Key to a Pain-Free Life, which sounds like something we can all use a little bit of pain-free living. So we're going to talk about specifically the knee this week. As many of you know, I've had knee surgery maybe like 10 weeks ago. So we're going to talk a little bit about knees, how to take care of them, what to look for in an orthopedist, the repair process, and some of the minutiae like what is a meniscus, what is cartilage, how do all these things work. So we're going to get with Dr. Alan Reznik in just a moment. So this week's update, I feel like, remember that SNL thing, like Weekend Update? Yeah, I loved Weekend Update. It was great. I love those old SNL ones. Like, remember the Bassomatic? If you know what a Bassomatic is, hit me up. David at superage.com and tell me if you know what a Bassomatic is. This week, I am in Park City, Utah, and my wife is traveling. My wife is actually in Australia, and she travels a bit for work. You know, we've been together almost 20 years, and you would think I would get used to this. I don't. I like to support everyone in doing what they do to actualize their power in life, but I don't really like being home alone. I just don't. And it took me a long time to realize that I didn't like being here alone. And, you know, for maybe the first 10 years or so of this, and it's not, you know, she doesn't travel that much. Every couple of months, though, she goes away for like a week or 10 days, and it's awesome what she gets to do. But what I would do is I would be very passive aggressive and just be sort of like super grouchy when she came back. Like I would want to like punish her for leaving me or something. I don't know. Now I don't do that. I tend to really celebrate when she gets back, but I still don't like being here alone because it means I eat a lot of my meals alone and I have to sort of fend for myself. I'm fairly good at taking care of myself, but it's not the same. Like I'm just used to having her around and we talk about all kinds of things. One of the great things I like about my life is I get to talk all the time with my wife about stuff that's on her mind, it's on my mind, and it's way harder when somebody's two hemispheres away. And so that's sort of what I get up to here. It's, you know, sometimes I threaten, it's like, well, I'm going to go camping by myself and go on a solo surf trip or something. I never do it. You know, I always just sort of continue to do what I do here. I guess what amazes me about my sort of attitudes and behaviors is that I have the capacity at 64 years old to essentially throw like a little tantrum. And you would think that we sort of outgrow this. Well, I've outgrown a lot of that behavior, but a lot of the feelings are still there. What can I say? We get better. And somebody once told me there's no limit for emotional immaturity. Like you can be advanced in chronological age and still be emotionally immature. And I think in a lot of ways I still am. And this is one of the reasons why I push back so much on people who say, well, you're so wise, or at a certain age you're wise, or you're mature, or you can, I don't feel that way. I'm happy that other people feel that way about me, but I don't personally feel that way. And I think I have many decades to go before I get to mature wisdom. And I think there are other people I know who are my age who are way better at this. I think they had much better guidance in their younger years. I was one of these like latchkey kids in the 60s and 70s. And, you just sort of fended for yourself. And I had very little parental direction or like mentor. What was that? It's taken me a little while. I have a little bit of a handicap there, but still getting along. Anyway, we are going to get with Dr. Alan Reznik. We are going to talk about the knee, a very important part of the human body, in just a moment after we have a quick word from our sponsors. Today's show is also brought to you by Timeline Nutrition with their breakthrough product, MitoPure. MitoPure is the first and only clinically tested, highly pure urolithin A postbiotic. There have been over 300 published scientific studies on urolithin A, including human-completed and ongoing clinical trials involving over 900 participants. The results are impressive. By energizing cells, MitoPure is revolutionizing cellular aging. Urolithin A is the only known substance clinically proven to trigger a crucial recycling process within our cells called mitophagy. I've been using MitoPure for several months. The members of our scientific board and their families use it, and many of our friends use it because we have read the science and we can feel the difference. This is a product I'm going to be taking for as long as I possibly can. Receive 10% off your first purchase at timelinenutrition.com/ageist. Use the code ageist at checkout. Today's show is brought to you by Ned's Mellow Magnesium. It's a sleep supplement that I've been taking for about 3 weeks, and it's great. I know a lot of you guys, we have problems sleeping. We wake up in the night or we have trouble getting to sleep, and you should check this out. So it's got 3 different kinds of magnesium. Magnesium is awesome to help us sleep. It's also one of the minerals that 75% of Americans are not getting enough of. Mellow Magnesium also has L-theanine and GABA, both of which are going to help us sleep. And full transparency, Ned shares all of its third-party lab reports right there on its site. So not just the research they do, but the research that everybody else does on their products. And that strikes me as a real vote of confidence from the brand on the products that they do. They have over 5,000 5-star reviews on their products. So I'm not the only one who likes this. You can't become the best version of yourself unless you're getting great sleep. Like nothing else works. You got to get sleep. So this is what you do. Go to HelloNed, that's HELLONED.com/ageist and get 15% off on all their products. Or if you forgot all that, just enter ageist, code ageist at checkout, and you get your 15% off there. A quick reminder, after my conversation with Dr. Reznik around the knee, we're going to be having that thing that we do every week called Just Try This. Quick little fortune cookie to help you live a little better, a little happier, a little longer. So stay tuned for that. Dr. Reznik, great to have you with us here today. How's your day been so far?
Well, thanks for having me on the show. Yeah, the last couple of days been a little busy. I did 5 surgeries yesterday. I got a couple of surgeries scheduled tomorrow. And in between, I saw patients today. But to loosen up for the show, I did a little quick bike ride to loosen up the joints and get myself moving. Heavy exercise sometimes is a little too much, but a little light exercise keeps me going along the day. So I try to sneak in some exercise when I can once in a while.
Good for you. You're probably one of the most sensible physicians I've ever spoken to. So Dr. Reznik, tell us a little bit about your background in orthopedics.
I'm an orthopedic surgeon, and I practice orthopedic surgeon sports medicine primarily in my practice. I've had training over many years, and I did my original training in engineering and then came to orthopedics from that direction. So the mechanics of the knee and the shoulder and all the joints and bones was sort of attracted to me when I finally got that around to that medical school. And then I also did carpentry when I was a kid, and I taught wood shop, and my dad was a master carpenter and engineer himself. So putting all those things together with the love of medicine, bones and cartilage and joints and mechanics, all made a ton of sense to me. And sort of I fell in love with orthopedics. And then inside of orthopedics at the time, sports medicine was in its infancy, and the ability to look inside joints with a fiber optic telescope was just coming to be in a very big way. And the understanding of the mechanics of the parts inside the knee were also coming to the fore. If there was a period of time when they thought the meniscus was a vestigial object and wasn't even required, and you could just remove them willy-nilly and it wouldn't do anything to the knee.
Make a picture for me. Where in my knee capsule is the meniscus?
So if you imagine the tibia like a plate, right, and the femur like a ball, right, or two balls next to each other, right, then, there's a mismatch between a round shape and a flat shape. So if you imagine a triangular bushing or like washer that's triangular in shape so that the edge was narrow in the inside and fat on the outside, you can make the ball and the plate match up. Does that make sense? So if I match the ball and plate shape, so now it's more cup-like, I can spread the load on the plate more evenly, and I can reduce the stress on the point of the ball because not all the weight's going through the bottom edge of the ball, right? And that's what the meniscus does. It takes, in some cases, up to 50% of the load across the surface goes through the meniscus. So if you imagine point loading with 100% versus 50% in the meniscus, 50% on the ball's going to last longer if you get 50-50.
And is this loading throughout the range of motion, or is there more loading on the meniscus as we increase the angle?
That's a lot more complicated because the knee is a cam shape. It's not really perfectly round, and there's a lot of mechanics there. So it turns out that the lateral meniscus actually moves back with the femur as the femur rolls back. So this is why I was an engineer first, right? The mechanics of the knee is super complicated. It's probably well beyond the course of what we could talk about, but just have it to say that it tries to track really nicely with the femur as the femur moves through its range of motion. So it maintains as much of its weight sharing as it can in all ranges. And Mother Nature is pretty smart about that. And if we muck it up, it doesn't work as well.
So let's stay on this, the meniscus and the repair. So what I had was a clean out. So there weren't any stitches involved. What is a clean out? What are they doing when they do that?
So, there's several types of clean outs, right? So let's say I have a carpet and the carpet's got a lot of pilling on it, and little fuzz balls all over the place, and it doesn't look so good. And I remove all the fuzz balls and smooth it out again. That would be one type of clean out. But let's say the carpet in the corner, maybe the carpet's not the best analogy, but the carpet in the corner has a flap that keeps getting stuck on the door, right? And every time I open and close the door, that flap flaps up and gets stuck, right? So if I could glue it back down, that would be a repair. That would be okay. But it turns out if the glue won't work and I just trim that piece off, the carpet won't look so good in that little corner that's flapping up, but it'll stop trapping on the door when I open and close it. So the meniscal repairs that you can sew back and glue that carpet back down, that's one type of repair, right? And the other type is, okay, that flap is never going to stick. There's no blood supply. There's no way the glue is going to work. It's too thin, but the door won't open. I got to cut that flap off. I know it's not going to look so pretty inside, but at least it'll work a lot better. So that's really what it is. I'm going to make it look not so pretty on the inside, but I'm going to give you a better function. Not ideal, right? Because we're not saving the cartilage there. Whereas the other one is, okay, I can glue that carpet back down and make it perfect, right? And then that's a lot better in some respects. But the reality is Mother Nature doesn't care what we think. It deals a deck of cards and you got, 3 2s and a 5, and maybe a 4, and the other guy's got 4 5s, whatever, he's going to beat you every time, right? So, you get the cards, they're dealt with you, you look inside with the scope and you decide what hand we have in poker, let's say, and then we play the hand as best we can. I always like to say to my patients, like, at this point, I'd like to think that maybe you have a surgical problem. Now would be the time to get an MRI because I'd like to play the game with knowing all the cards. The truth is, I started practice before MRI was invented, and I would say 90% of the time I know what's wrong before I get the MRI. And in fact, most of the time, you don't need an MRI to know what's wrong. If you have bad arthritis, you take a plain X-ray. There's bad arthritis on the X-ray. You don't need an MRI. You know what's going on. It's bone on bone. You need a knee replacement, right? An MRI will confuse things. So the MRI will say, oh, the cartilage is torn and worn and the surface is this and there's bruising here. And you say, can you fix all that? No, it's all shot. You need a knee replacement. So the MRI doesn't change the decision making. So I think people get carried away a little bit with MRI. They think like, oh, I hurt myself. I need an MRI immediately. The reality is you need a good exam and probably a plain x-ray if you really hurt yourself. And sometimes you have a fracture. Okay, well, a fracture, I see it on the MRI. I have someone operating on Friday, fell down a flight of stairs, has a tibial plateau fracture. Actually, this is in the book also. And she doesn't need an MRI. The best study next is a CAT scan, because a CAT scan will show the bone fragments infinitely better than an MRI will. And a CAT scan can do a 3D reconstruction of the bones. And I could see in 3 dimensions and rotate it on the screen and actually see where the fracture fragments are. And surgical planning with that for a tibial plateau fracture is infinitely better than an MRI. And conversely, if you tear your ligaments, CAT scan doesn't show them as well. You can actually see them, but CAT scan is not as good. If you have a soft tissue tumor, CAT scan is not as good. But if you have a bony tumor, CAT scan might be better. But very often, plain X-ray and a good exam, you know what's wrong. Probably 90% of the time.
Excellent. This sort of trimming of the carpet, I really love this analogy. When I had my knee done, they sent me pictures of the before and after of the inside of my knee. It was just like magical to me. And you could see the before, it was a little ragged, and then the after, it seemed quite smooth. What they told me was that even though it's been sort of polished out, it's still going to take, like a few months for the surfaces to mate again. Does that make sense?
Yeah, there's a couple of layers that I have to unpeel for that one.
Okay, go ahead.
So the first thing is, I've insulted your knee. I had to put a scope in, I clean it up, I move things around, and I irritate, and there's little ports that have to heal. The ports on the outside, the skin heals within a week to 10 days. Underneath, your body makes scar tissue around the tendons and all that, and that gets a little thick, and then it has to come down, and the knee is a little aggravated. If I clean, let's say the lining, you have a torn cartilage, you're walking around a while, the lining will be red and inflamed, and the lining will make extra fluid, and all of that has to settle. And sometimes that takes 4 to 6 weeks. And then you've been walking around a bum knee for a while, you might need a little time for the muscles to get kind of used to the fact that you're not guarding anymore. You're not trying to protect it when you walk. You're actually trying to use your quads more normally. That may take another 6 or 8 weeks even to get there. So now we're like 3 or 4 months out before you really start to feel decent. On top of that, there is, in certain circumstances, if there's a little bleeding there, the body will make fibrocartilage on top of the old cartilage, which is not the same as the initial cartilage. It's not as good quality, if you will. It's a little softer, maybe a little less flexible. And there's some theoretical advantage that might help a little bit, but it's not like giving you a brand new meniscus, right? So it's not really the same. And sometimes that helps a little bit too. So, there's a little, if you unpeel the onion, if you will, there's layers of that. And part of it is some people form keloids. You ever see people with very thick scars? Mm-hmm. Someone has a cut and the scars are ultra thick. I mean, it's usually genetic. Different people get it. Some Mediterranean people get it. African people or dark-skinned people get it. And some people just genetically get them. It doesn't matter what your heritage, but your family members have it. You have them. Once you get them, you have them. And sometimes people who form keloids will get very thick scar in a tiny little port. And that thick scar might actually aggravate the knee a little bit, and they won't want to fire their quads. And those people might have a hard time getting better. And occasionally those people, we have to treat the keloid to get them better before their knee will feel good. And sometimes that means hydrocortisone cream. Sometimes that means a silicone Band-Aid to get it to flatten. And occasionally it might mean a cortisone injection. But that's a very small percentage of people. But when it does happen, it's annoying. Like I had this little scope and I got this thick little marble in the front of where the scars were. And all 3 scars feel like tiny little marbles that are there that bother me. And that's a separate problem. But that can happen. It's one of those little complications that we don't talk about a lot because it's uncommon. So again, like unpeeling the onion, there's a lot of layers to that question.
Let's go to cartilage. What is cartilage? Does cartilage, like you mentioned, sometimes there's blood supply and sometimes there's not. Help people. What is cartilage?
Okay, so cartilage is that the classic meaning of cartilage, right, is the surface of the bones are covered by articular cartilage. That is that smooth white stuff that has the lowest friction component of anything in the world practically. I mean, there are things that are better now, but for years and years, the ability for cartilage to lubricate itself and move smoothly was so unbelievable. People couldn't even figure it out. And it turns out that in between the cartilage, there are little pits, and in those little pits is hyaluronic acid, which is a special giant molecule. So the acid is like this big and the molecule is gigantic. And that molecule imbibes water And that water makes these little ball bearings of water, right? And that makes the friction so low that, you can have a knee for 100 years. How many people have a tire that lasts 100 years in our car? It never happened, right? But the cartilage is alive. It replenishes itself, and it creates this surface that is super lubricating, right? That's one type of cartilage. Then there's the cartilage in your nose and the cartilage in the bottom of your ear and all those cartilages. And then there's meniscal cartilage, which is the meniscus you tear, and that they're a little bit different. So the components of the cartilage, the amount of collagen, the type of collagen, and the other components of it are different because they have different functions and different durability. But there's multiple types of cartilage in your body. The two main types are the cartilage of your meniscus and the cartilage on the surface. Both really don't have a huge blood supply. The cartilage on your surfaces have no direct blood supply. It gets nourished by the fluid in your knee. The oxygen nutrients are carried in the little bit of liquid that's in your knee, in the hyaluronic acid that's floating around your knee, carries the nutrients. And they're very slow metabolic structure. They don't do a lot of metabolism once the cartilage is formed. Hence, if those cells die, it's hard to replace them. Your body doesn't really replace them. We'll get to like ACLs and stuff like that. If you injure your knee really badly, like an ACL tear, you sometimes bruise the bone and injure the cartilage. And sometimes 50% of the cartilage cells in that spot have died and they're not going to come back. And so I repair the ACL, but maybe 10 years later, the knee becomes a little arthritic. Why? Because you killed the cartilage cells in the initial injury and you don't even know it until later because that cartilage isn't maintained as healthy as it used to be. Whereas the meniscus, the outer third has a blood supply and that's repairable and the inner third doesn't. And that type of cartilage can have the potential to heal, because it has some blood supply to it. Very different structures, really.
We're going to circle back to cartilage and transplant and perhaps regrow, but I want to ask you about this lubrication issue. Now, a lot of us, we get up in the morning, we get out of bed, and things don't work. They're a little creaky. And then we move around a little bit, like you rode your bike, and maybe for the first minute, it just didn't feel quite right. But then suddenly the lubrication starts to go. What's happening there? Somebody told me there's something called synovial fluid. I probably butchered the name, but
synovial fluid is what has the hyaluronic acid in it, right? Okay. That has that. It's not really an acid, but it's that fluid is synovial fluid. The lining of your knee makes synovial fluid, and that's what carries the nutrients. So the lining supplies the nutrients, and the fluid carries them. Some people, here we get a little sidebar for a second. Some people we feel don't make enough lubricant, and their knees are not doing so well, and they're a little creaky. And there is synthetic lubricant you can inject, which is the same hyaluronic acid or close to it. It's hyaluronic acid, all different molecule sizes, but there's a few companies that make it. And some people believe that supplementing hyaluronic acid for people who are older and they don't have terrible arthritis, that's a distinction. Like if you have bone on bone, this is not going to help you. But if you have a good amount of arthritis, but your knee's creaky and painful, some people get 6 months, 9 months, or a year of symptomatic relief from injecting hyaluronic acid into their knee and supplementing the hyaluronic acid that's in your knee and giving you more lubrication. So that's synovial fluid. Now, synovial fluid has a lot of other roles, right? Like if I get an infection in my knee, I make a ton of fluid. If I hurt my knee, the knee might swell and might have a knee effusion of water in the knee, right? The synovial fluid is that fluid too. And the lining also does protection against infection. So the lining can get red and inflamed. And in fact, you look at a knee and there's a lot of synovial fluid. It might look like seaweed in there. There'll be a lot of red inflamed lining that actually looks like seaweed, like Jacques Cousteau under the water kind of thing. And that's called a synovitis. The lining is irritated. So I might see a knee that's got a meniscal tear and some calcium deposits, maybe even gout might be in that knee, or pseudo gout, which is a little different crystals of calcium. And the lining will look like a sore throat. It look terrible. Now, you can clean the lining out. You can use anti-inflammatories and it might heal and you might be able to get rid of the inflammation. It might be curative. But if you had Lyme disease, you'd have to treat the Lyme, right? You get a synovitis from Lyme disease because it's an infection. And if you don't treat the bacteria, then that synovitis isn't going to go away. Lyme is a little complicated. It has multiple stages, but the initial phase that's in your knee, it's really stage 2 Lyme. That would have to be treated with an antibiotic. So just, start to think about the differential of a swollen knee becomes quite big. You could have gout, pseudo gout, Lyme arthritis, rheumatoid arthritis. You could just bang the knee really badly and bled into your knee, or you could just have an inflammatory arthropathy like rheumatoid or lupus or something like that. So it's complicated. It gets complicated very quickly, but the synovium makes that, the lining, and the synovial fluid is that fluid.
Got it.
To come back to what you asked, yeah.
And in order to get the lining to make the fluid, I need to move the knee, right?
Yeah, to some extent. I mean, if it's really inflamed, the lining will make fluid no matter what, because the knee is very smart. It does two things when it's mad. It makes fluid or it hurts, or both.
Oh.
Right? Those are the two things the knee can do, right? And any joint, in fact, that's true of all your joints. It's always making a little bit of fluid. When it has a lot of fluid in the knee, something's typically wrong. That's a tip off. My knee's very swollen all the time. There's something going on there that my lining doesn't like, right?
I'm very curious about this idea of cartilage. Is it possible to transplant cartilage in the knee, this specific kind of cartilage, or can we regrow it some way?
Yeah. So again, this is, it really depends on the size of the defect. Okay. So like there's criteria, it's the scientific criteria, and the insurance companies love this stuff because they block out what you can and can't do based on the scientific criteria, which does make some sense. So very small defects, you could stimulate the marrow. You can make little holes in the marrow and you could get stem cells to grow in and they'll grow some cartilage there. It still won't be the same as normal cartilage, but it might regenerate a little bit. You can take like a hair plug. I could take a round plug of cartilage from someplace else in your knee that you need less and move it to a place where you need it more, just like a hair transplant, right? Little plug of cartilage with bone and move it over. So that's the next level. The next level gets a little more complicated because big defects, sometimes they're so big, you actually have to take a fresh frozen piece of cadaver cartilage from someone else and actually transplant it. And you can do that with the meniscus, not commonly done, but it can be done. And you can do that with a big defect. Like one time I had a 21-year-old bad motorcycle accident, sheared off probably 70% of the medial-femoral condyle, half of the knee joint. And I was able about a 2 centimeter, which is about an inch in diameter, plug from a cadaver that was matched to his size of fresh frozen cartilage and put that plug in and regrow the bone and the cartilage there because it's a plug of real cartilage and something that was matched up in size. And that's complicated. You get an MRI, you measure the MRI, then you go to the bank and you say, and we had to wait 4 months to get one that would match, that was fresh. So that's a little complicated. Just like a kidney transplant, a lot different, right? No problem with rejection with this, though. That's the good news, is because cartilage and bone and everyone's the same. The cells are different, but you don't need the cells. Your own body populates the cells. And the last one, which is becoming much more popular, and I've done a number of these, and I have some patients in waiting for doing it because they've taken the cells, is you can go in arthroscopically with the fiber optic telescope and take little samples of the cartilage, like little tiny chiclets or little chips of cartilage out of the knee from the middle of the knee on the edge where it's not that important, send it to a lab and give them 5,000 to 8,000 cells and they make 8 million to 10 million cells and they grow it in culture. And then they take a piece of collagen, which is made as a matrix, almost like a piece of cloth. And they impregnate your cells into that little thin piece of cloth that's made out of collagen, which is part of what you have inside your knee anyway. And you can then glue in that into a defect and it'll regrow your cells. And that's been shown to work for a lot of interesting things. And I have a number of patients that it's been quite successful in. It's not always successful, but when it's successful, it's amazing. Again, for younger patients, usually younger than 40, 45, and usually bigger defects, something that's 2 centimeters square, or 4 centimeters square, bigger defects, and isolated injury. Like I knocked a piece off somehow. I had a traumatic injury and there's a piece of cartilage missing and it's in a important place. Like, so where my knee weight bears the most on the femur. And that area is just no good, but I can put cartilage back and grow it. But it is a bit of a process, right? You have to do 2 operations at minimum because you got to harvest it, grow it, and then put it back.
Do you see this in the future as something for arthritis? Could that be done?
That's different. So if you have arthritis all over the place, these things don't work because the criteria for doing it is within a certain size range. Right. And also the wall, you have to be able to put in a spot that has good walls. So it has to be like a nice sized pothole that has good walls around it. If the walls around it aren't good, it's very hard to find a place to put that matrix and glue it in that'll actually stay. So you can't really coat the whole surface and get structural integrity. But, if you have a nice defect with a good wall, you can do that procedure, and that works relatively well. Nothing's perfect, but it seems to have helped quite a number of my patients.
Then let's go to somebody who doesn't have cartilage, they have terrible arthritis. And would you be looking at knee replacement then?
Yes, you could look at knee replacement. Again, it depends on your age, right? Knee replacement, and I like to tell my patients, unlike normal cartilage and bone, knee replacement doesn't regenerate itself, right? It's a mechanical device. So your normal cartilage and bone, every night you go to sleep, your body is trying to repair it, and it does things to add more collagen, more matrix, reinforce the bone when there's more stress and so on. That's why it lasts so long. But once you put a metal plate and a plastic liner and another metal plate on the bone, and that device is in there, it will wear at a certain rate. Now, the newer materials are very, very good, and they wear very slowly. The older materials wear much faster. So they're quite good. And if you're, don't have a super active lifestyle, but you're active, you're not a marathon runner, and you put it in, it could be good for 20 or 25 years in knee replacement. But if you give it to someone who's 17 and say, well, go out and do whatever you want, it might not last 10 years, right? And then you're looking at a revision. And it turns out that every time you revise a knee replacement, the results have more risks and complications. Because every time you go into the knee, there's more scar tissue. Every time you open it up, there's more chance that you're going to infect it and so on. So you can't say, I'll just do a knee replacement every 10 years. I'll revise that. That doesn't really work. So our goal most of the time for most people is to try to get you to a place where we could do one and done. You could do a knee replacement when you're 60, 65 or 70 or 75, and then it's going to last to 90 or 100, right? And you say, okay, I'm going to put this knee in and hopefully it'll be good for the rest of your life. And we try to avoid these situations if we can, where you have to replace someone's knee, where you're going to end up looking at 2 or 3 revisions in their lifetime. And that's going to be more problematic and with more risk. Not saying that you can't do that, but it's not ideal at all.
Do you have preventative strategies for reducing the wear and tear on the cartilage?
Yeah, there's so many things you can think about. So let's say ACL tear. So if you're an ACL tear and your knee is unstable and you remain active, we know that down the road, if your knee is unstable, that you tend to get cartilage injuries. In fact, there's a lot of great data in kids, the young kids, that they get an ACL tear. Their likelihood of tearing their meniscus goes up dramatically, the likelihood of damage to the cartilage. And even in 1 or 2 years after an ACL tear in a young kid, we're looking at damage that will be lifetime, right, and problematic. So if you have an ACL tear in someone young and they're unstable, and I'm going to qualify that in a second, then you probably want to fix that so you reduce the instability and reduce the risk of meniscal tears going forward, right, and cartilage damage going forward. If you have someone who has an ACL tear and they're not unstable, and there's ways to measure that and figure that out, and they have low demand. Let's say I just played tiddlywinks and I have an accident, I tripped on a curb and I tore my ACL, but it turns out all my other ligaments are excellent, and you test me and there's very little difference between my 2 knees. Well, maybe a little rehab and a brace might be fine. You don't need a reconstruction. But let's say you're an elite athlete and you tear your ACL and you have some instability and you play at 99.9% of your max all the time, you may be unstable even with a knee that's subtly problematic, and you're looking at maybe more injuries down the road if we don't stabilize your knee. Having said all of that, if you look at long studies, and let's say I have a very traumatic ACL tear, like I got piled into in football and I tear my ACL and my MCL and I bruise the bone and I tear my cartilage all in one shot. Remember I said before, the cartilage cells could be killed by trauma. And then I killed off 50% of my cartilage cells in that injury initially. I could stabilize the knee, fix the meniscus, do everything, but part of the die has been cast by the fact you knocked off some cartilage cells that are not going to come back. And everything will look fine, and the x-rays look fine, and everything will be hunky-dory. Down the road, you might pay a price for that. So, something we can't, been hit by a truck, we could put you back together, but I can tell you can have a lot of scar tissue and things aren't going to be normal, So, that's the difference.
With these ACL, MCL tears, I want to address a couple of things here. So gender differences. I've read that women playing sports, it's something like 4 times the likelihood of an ACL tear as men. Why is that?
Yes. Yeah, it's believed there's several reasons for that. One, anatomically, women's knees and men's knees tend to be a little bit different. the notch where the ACL lives, the space in between the bones where the ACL fits, is in some women very narrow, and they talk about an A-shaped notch where it's kind of pointed and high and tight. So that puts the ACL in more strain. There's also a concept that biomechanically women cut and turn and land differently than men. And there's actually programs to teach them how to cut, turn, and land and change direction to teach their muscles to do it differently and reduce. And it's been shown in high-level sports that you can actually reduce the injuries by doing that. Some people believe that hormonal levels vary during their cycle, their hormone cycle, and that when their hormones are the most, that some of the ligaments are actually a little looser, a little more pliable, and actually softer. And they believe that that's part of it. So those are the three main reasons. And then the other thing is hours of participation. So women, because they have reasons for increased risk of ACL tearing because of the anatomic factors, the way they cut and land, and maybe hormonal reasons, if you increase the hours of participation, the risk per hour is higher than men. The total number of injuries will go up. So before they had I think it's Title 8, when women's sports were elevated to men's sports in schools and stuff, where they said, okay, everything's got to be equalized. Before that, women's sports were not practiced as much. The practice times of the seasons were shorter and less participation. ACL injuries were just as common in girls and boys. And as soon as they made it on par, the amount of hours to play and the competitive level went up, women ACLs started to outnumber men. So there was a time you had an ACL tear and played soccer and had college scholarship, they wouldn't take you. Now it's so common to have an ACL tear, have a reconstruction, return to soccer, that having an ACL tear is just considered a 1 year out, and then you go back, because you can reconstruct it and repair it, and you can go return to play. So the thinking about it has changed. The participation levels have changed. The risks still remain higher, but there's certain things you can do to reduce or mitigate those risks as well.
How do you repair an ACL? Say I tear it. So what are you going to do?
Yeah. So in general, most of the time, ACL is really not repairable. There is some stuff now, some new cutting stuff where you might be able to repair an ACL. And I'm going to make a distinction of the word. So when you have a rope and you pull it really, really hard and it ruptures in the middle, the ends of the rope explode. You've seen that, right? You pull hard enough, pull, and it goes like that. So in those settings, the collagen in the ligament have really been disrupted, and the quality of it remaining is really poor. And if you try to sew that back together, it just doesn't have the same mechanical properties. So in that setting, it's really better to replace the ACL with a new ligament. And you could take a hamstring tendon or a patella tendon or a quads tendon from the person, or you could take a frozen tendon. There are different reasons and pros and cons to doing all those things. And then you can put that in its place. And in general, we do it, and it works very, very well. On the flip side, you can, and young, you can tear the ACL directly off the bone with a little fleck of bone from either the femur or the tibia. And if the ligament itself really hasn't been deformed by the injury too much, you can actually sew it back and get it to heal to the bone and repair it. Now, there is a newer thing where we do, it's actually a sleeve of biological material, and you sew it back and add this sleeve of biological material, and then you can repair it back with that, augmenting the natural ligament with this extra biological sleeve. And there's some data showing that seems to work. But again, it's very limited circumstances where that's the right answer, because it has to be a tear where the substance of the ligament itself hasn't been destroyed by the injury, right? And it has to be very injured very close to the bone. So it's a very small percentage of the injuries are even remotely candidates for that. And you have to be on the younger side. You can't be 50 years old and say, oh, I happen to have a tear near the bone, not on the bone, but near the bone. Give me the biological repair. Probably not going to work.
From what I understand you just said here is you would take part of a patellar tendon or hamstring tendon and then put it in its place. So now we have two injury areas, right? We've got the place that you removed and the place you put in.
That is complicated. Yeah, that is complicated. We have a heart-to-heart with the patient about that. There is an alternative using a frozen cadaver tendon. And for some people, for a lot of different reasons, it makes sense to use that instead. And in my practice, I found that certainly people over 40 and 50, the donor site, morbidity, taking the donor site, sometimes for some of those patients. And I learned this the hard way with a very high level skier. I've had some skiers who are like national, international ski level at 60 and 70 years old, and they tear their ACL. And if you take their own patella tendon or hamstrings, they don't really regenerate as well. And they weaken those areas, and I've had one or two patients not really recover from that. And this is years ago, but when it happened, it was very surprising. They would take the tendon and they just don't really heal that well. And they always complain of anterior knee pain or weakness in their hamstrings. And that alone was more limiting than the reconstruction itself. So in those patients, I do talk to them about doing a frozen tendon instead. And in general, those patients that have a frozen tendon in that setting do very, very well. Now you can look at some of the literature and they start to say, like, below the age of 20, it looks like taking your own tendon might be better. But sometimes someone less than 20 isn't compliant. So maybe if you put a tendon in and they don't have a lot of pain because you didn't take your own tendon, maybe they do a little too much in the early phase and they re-injure themselves because they're just too active. So the answer to that, the common answer is younger patients get their own, older patients might get a frozen. In between, you have to have a heart-to-heart and make a decision. But I think longer term we'll have better answers even going forward after this, that every year we get better and better answers about what the right answer is for people. And we understand it better and better. But even now our understanding is 1,000 times better than it was when I started my practice.
Well, I'm 64 and I'm a ski racer.
Yeah. You'd probably get a frozen tendon.
Well, I hope that I never have to go in and do this. Good to know. That whole idea of like cutting the patellar tendon or the hamstring tendon, that just seems like bad.
Well, yeah. You take one, when you do the hamstring, you actually take one whole hamstring tendon out. You take the whole hamstring tendon out. So you leave the others, but you remove one. When you do the patella tendon, you do the central third, and the other two sides fill in eventually. But the middle third of your patella tendon is removed, and then you want scar tissue to fill in after.
And then, in your experience doing an ACL, what are the looking forward 10 years ahead? Does the person have a higher likelihood of arthritis?
Well, like I said before, if there's a lot of damage to the cartilage surfaces and the ACL doesn't really work, it doesn't really stabilize the knee, for sure. And there's a lot of technical factors there, right? Is it placed properly? Was it tensioned properly? What were the mechanics of the knee at the time of the surgery that makes the ACL positioning anatomic and then work the right way? And there's ways to check that while you're doing the surgery. So that's the technical component of it. And the other piece of it is, like, was the articular cartilage really damaged badly, right? So if the ACL is successful and the articular cartilage is not damaged badly, then I think most people will do well. I have a patient who I see periodically that I did his ACL over 30 years ago, and I've actually followed up on him. And he tells everyone that he hasn't had a lick of pain in 30 years. His knee's perfect. And I've taken an x-ray 25 years after the initial, and he doesn't have a drop of arthritis. And I did his ACL using a lot of scientific methods that we now really understand as being, the gold standard for it. I was very fortunate. I trained with someone who was also an engineering kind of guy. And he had all these ways of measuring how the ACL is done to make sure it was accurately placed. And using those techniques, now we understand where it should go. And basically all the ACL techniques have kind of converged on the idea of where the ACL should really be when you do the reconstruction. I think we were less critical about it 30 years ago. And the ideas have evolved over the last 30 years. So now we kind of really understand much better how to put it in, where to put it in. The fixation methods are better, and the quality of the reconstructions are better. And if it's done properly and there's less cartilage damage, then people can do well for a very long time. Doesn't stop people from re-injuring themselves, though, going back to full sport, because I have that too.
Let's take somebody who, say their knee is stable. They don't have any ACL issues. I'm going to say they're moderately sporty. They're not world-class anything, but they're, pretty active. Are there things that they can do to reduce the wear and tear in their cartilage?
Well, I think there's a lot of interesting things we could talk about in that area. I mean, I think listening to your own body is important. So like some people say, oh, every time I run, it hurts. And I think that's good because I'll run through the pain. And I like to tell people, make a distinction for yourself. Like if it hurts in the muscles and they're sore and the next day it goes away, that's normal stuff. You're training, you're up to training, muscles hurt. If the joint itself hurts or the joint itself hurts and then swells, that's a little different, right? So I would be more leery if like every time I train, my knee hurts, but I run through the pain. It's so good for me. And by the way, it swells and I have to ice it for 2 hours and I take 6 Motrin for the next day. And then I can train again 2 days later. I think there might be a problem. You need to have it checked, right? Whereas like, okay, my calves are sore and my quads are sore because I just did this crazy workout I haven't done in 6 months. And, I've been limping around for 2 days because I'm just so sore in my muscles. Do your joints hurt? Nah, they don't hurt at all. I'm just overdid it. It's okay, not okay, maybe. And then I say, beware of things that are funny, but not healthy, right? So we all know the people in the gym, when you listen to them run, it sounds like a pile driver, right? They're on the treadmill. It's bam, 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 bam. You could hear them across the whole gym. Mm-hmm. Other people on the treadmill, it's whoosh, whoosh, whoosh. You barely hear them. I can tell you the bam, bam, bam people are like, it's like hitting your knee with a hammer. That loud noise is your heel strike is heavy. The forces go through your knee and your hip. It can't be great for your back either. It's probably not a good thing. And it usually happens because people have the treadmill set way faster than they can run. Okay. And what happens is they're falling forward so hard, they end up with a very heavy heel strike as they crash against the surface because their body's being propelled forward faster than they can catch it. So if you see that you are the bammer, right? It's a funny way to say that, but you're making more noise than everyone else in the gym. Maybe the stationary bike or elliptical would be better for you, or slow the treadmill down, one or the other, right? Because I think you're going to get in trouble over time. So I think listening to your body, looking for good mechanics, paying attention to things that, clearly are hurting the joints over the muscles are really great ways to save yourself from some grief later on in life.
Let's assume someone is having a problem with their knee and they want to see somebody like yourself to evaluate and then possibly surgery. What sort of advice would you give for people to how they would source a good practitioner, and then how to discern whether, no offense, but surgeons often like to do surgery, and whether that's the right thing for them?
Yeah, so that's a very hard question because you can't get into the mindset of every individual, because some people come to me, they want surgery, they don't need it, and they can't convince them otherwise. And other people come to me and don't want surgery and absolutely need it, and I can't convince them otherwise. And they'll doctor shop, right? Until they find the doctor that agrees with the plan they wanted to hear, right? There's an old joke, you have cancer, you never survive your third opinion. And I have patients who see me and I'm the fourth person they've seen, and they don't believe me and they don't believe any of the other people because they haven't heard the thing they wanted to hear. And that's not right. That's not good. So sometimes I tell people the truth. They don't want to hear it. That's a problem. So it works both ways. You can doctor shop and see if you're happy, but you can also doctor shop yourself into something that's probably a bad idea, too. So it works both ways. It's very hard. There are two components to knowing that the doctor's right for you. One is if you're comfortable asking questions and they're willing to answer them, right? Most doctors will explain what they're doing, will give you some reasons for it. You usually have a sense you feel comfortable whether or not you trust them. I don't like the idea of relying on online reviews, but sometimes online reviews do help a little bit. If someone's got 5 stars, it's good. If they got 1 star from everybody, maybe not so good.
Absolutely. I picked a doctor who did my knee because he does all the knees of the U.S. ski team. And I thought, they probably know. And somebody like yourself, if you're doing elite athletes, they check around. I do want to say, being a recent patient, I have up on my desk now a perhaps 20-page document from the insurance company with all these codes and costs and all this. I'm not particularly dumb. And what? I have no ideas.
No one can figure it out. I had the same thing. I'm a physician and I get that. And I look at the insurance company thing and I don't even understand what they're talking about. And in fact, we have a team of people who are coding experts who deal with it because it's it's so much information that if I actually took care of you and kept up on the literature for orthopedics, I couldn't possibly do that as well.
Right.
Yeah.
It's just madness.
Yeah.
What can we leave people with today? What do you want to tell my people today?
I like the idea of listening to your body. I like the idea of understanding when things are not right, that the pain is persistent, it's recurrent, there's some swelling associated. I have a section in my book called Sports Tumors, and I have a couple of vignettes in there, but one of them I'd like to share this last little one because I think it's very important for parents and coaches, although children don't get tumors very often. But I had a kid, wrestler, could not get in the wrestling position, couldn't get it all the way down. And they tried therapy and they were ranking on his leg and pushing him and massaging it and wouldn't move. And finally, somehow, miraculously, the child came to me for evaluation. I was a teenager, about 15, 16 years old. And I took an x-ray, just a simple x-ray. His knee wouldn't move. And he had a bone growth behind the back of his femur that was blocking his tibia, which was actually bone. It was a bone tumor in a dangerous area because the blood vessels and the nerves sit right on top of it in that area. So I removed it. And he had phenomenal improvement. His range of motion came back and everything was fine. And it's not the type of thing, if you remove correctly, won't recur and it should do good. The reality is they could have done everything to Sunday. That knee was not going to move. And at some point, you got to say, okay, time out. We got to see a doctor. We got to see why this knee's not moving. Got to go to a chiropractor and get that manipulated. So in the end of the day, for most diagnoses, a good history, matching up the injury with what happened in the exam, a good exam to match up what the physical findings are, and a plain x-ray to assess the bones. And those three elements together in a good exam, most things can be figured out. And if it comes to that, you might need surgery because it's a mechanical problem. And maybe then you're going to get an MRI, or there's no clear diagnosis and things are still awry. You might need an MRI at that point. MRI overreads and underreads certain things. We know that. So I do want people to be aware that if you're 65 years old and get an MRI, a lot of people are going to have meniscal tears that are asymptomatic, and they buy themselves a surgery that they don't need. So jumping to the MRI is your first choice. I say to my patients, listen, do you want it? You don't have mechanical symptoms. You don't have any reason to get an MRI. I know that at your age, 60% of patients are going to have some kind of meniscal tear. Do you want to have a surgery? Because if I do the MRI, you're going to convince me that you're going to want a surgery that you don't need. So I kind of hold back on MRI in some settings just because I know the odds are it's going to be falsely positive in those settings, right? And it's not going to change your treatment course by getting it. So listen to your body, get a good exam if it's not right, get a good evaluation, give a good history, see someone who can ask questions of, and get an x-ray. And then if you need an MRI, sure. If you don't, maybe it's PT, injection, anti-inflammatory therapy, whatever you need, bracing, whatever works. The appropriate conservative measures first. And then if those fail, then maybe surgery if you need it.
Thank you.
Well, you're welcome. Thank you so much for having me. It was great talking to you.
Dr. Alan Reznik, his book, The Knee and Shoulder Handbook, Keys to a Pain-Free Active Life. The links will be in the show notes. Thank you so much. It's a pleasure to have you on today. The knee is one of those things that I was just, reminded from our conversation here with Dr. Reznik that everything's great until it's not great. Like I never really thought about my knee or really any of my joints. I don't really think about any of my body parts when they're working well. But when they're not working well, all of a sudden I become really grateful for them working well. So we want to keep them working well as long as we can. We're going to get with Just Try This after a quick word from one of our sponsors. Did you know that hair loss affects over 80 million Americans? Divi has created a range of hair care products designed exactly for thinning hair. All of Divi's products come together to create a full daily solution that helps both men and women nourish their hair to get to the root of scalp health. Some of their ingredients include copper tripeptide, tea tree oil, amino acids, and hyaluronic acid. Do you want to take back control of your hair and scalp health and do it with clean, science-backed ingredients? Well, we have a special offer for the ageist and super age audiences. Go to diviofficial.com/ageist or enter ageist at checkout for 20% off your first order. That's diviofficial.com/ageist for 20% off your first order. This week on Just Try This, I'm going to suggest we do a self-check-in. So there are many moments in the day where we have sort of a gap. Maybe it's between phone calls or between tasks that we're doing, and our natural reflex, at least mine anyway, is to grab my phone, look at the computer, check the news, something like that. My suggestion is this week that you just sit for just a minute. It's not that long, just a minute. Close your eyes and just notice what you're feeling, what you're thinking. Where is your body? How do your feet feel? How does your butt feel in the chair? Are you upset? Are you angry? What's the emotion you're feeling? What are the thoughts that are going through your head? And don't take any action on them. Just let them go and just notice what's going on. Bit of awareness there. So just try this. Let's take a little gap, a little bit of self-awareness that we can plug into our day. And you can do this, as many times in the day as you can. And that'll strengthen that muscle in our brains that will keep us centered on who we are rather than getting tossed around in the oceans of what may happen around us. Thank you so much for spending this last hour with us. We really appreciate it. We know all of you out there have a lot of other things you could be doing right now, and instead you chose to spend it with us. And we're grateful for that. Much appreciated. If you have an extra moment, please leave us a review. We love those. Leave a comment. Oh, those are so great. And if you could pass this on to someone you know who may enjoy the Super Age podcast. We got a lot of them now. I think we got, 157 of these. Oh my gosh, I've been doing these for almost 4 years. And there's a huge amount of information that we've had some great people on. So maybe pass this on to someone who could use it. And if you'd like to contact me, david@superage.com. I answer all of my email directly and promptly. Until next week, everyone, have a wonderful week. It's been great having you with us. Take care now.